Finals SAQ25 Acute Bronchospasm. A. List the factors that may have contributed to an increase in the prevalence of asthma in developed countries in the last 20 years. This includes better identification of cases influenced by targets for asthma management in primary care, hygiene hypothesis, cleaner environment associated with increased rates of allergy-associated asthma, obesity, increased risk due to altered airway mechanics and chronic inflammation, urbanization, asthma development following survival from premature birth, increased use of drugs such as beta blockers, NSAIDs, and aspirin. B. What are the possible causes of acute bronchospasm during general anesthesia in a patient with mild asthma? This includes pre-existing URTI, poor asthma control, and smoking, airway irritation due to cold-inspired gases, airway secretions, airway suctioning, laryngoscopy, intubation, extubation, aspiration, carinal stimulation, and endobronchial intubation. Drugs causing histamine release and muscarinic block or drug allergies can trigger asthma. Vagal stimulation such as peritoneal or visceral stretch can trigger bronchospasm. Additional info. What are the features indicating acute bronchospasm in an intubated patient? This includes increased airway pressure, increased slope of expiratory phase of capnography waveform, central trachea with bilaterally hyperexpanded and resonant lung fields with expiratory wheeze. Breath sounds may be absent if severe. Severe bronchospasm is a diagnosis of exclusion. The quickest method of ascertaining the source of increased airway resistance is to connect a self-inflating bag directly to the endotracheal tube, not the HME, and manually ventilate. If inflation pressure still feels too high, the problem is due to airway or ETT obstruction or reduced compliance. Eliminate ETT obstruction by passing down a suction catheter. Perform gently to prevent further bronchospasm via carinal irritation. C. Outline the immediate management of acute severe bronchospasm in an intubated patient during general anesthesia. Recognize and announce the emergency situation. Alert theatre team and call for help. Assess and manage the patient simultaneously following an ABC approach. Stop surgical or drug triggers when possible. Airway. 100% inspired oxygen. Ensure ETT is patent. Ensure ETT position is correct. Carinal or endobronchial placement may trigger acute bronchospasm. Suction if required. Breathing. Auscultate chest and confirm wheeze or absence of breath sounds. Check SpO2. Manually ventilate to assess compliance and apply higher sustained pressure for ventilation and longer expiratory flow time. Increase inspired anesthetic gas concentrations. Sevoflurane is the least irritant and less likely to precipitate dysrhythmias in the presence of hypercapnia. However, sevoflurane may be insufficient to break the bronchospasm. Circulation. Check heart rate and blood pressure. Optimize intravenous filling as increasing intrathoracic pressure reduces venous return. This leads to reduced cardiac output and causes a tamponade type effect. Drugs. Drugs used to treat acute bronchospasm includes salbutamol, which may be given IV, nebulized, or via puffs, ipratropium bromide, aminophylline, ketamine, magnesium, adrenaline, and hydrocortisone. Check for drug allergies to agents already administered. Once acute situation has resolved, monitor response with arterial blood gases, check electrolytes as beta agonist causes hypokalemia, arrange for chest x-ray, check for pneumothorax and endotracheal tube tip position, withdraw ETT if it is carinal, assess whether it is safe to proceed with the case or whether to abandon. Decide whether to keep the patient intubated and take to ICU or whether it is safe to wake the patient up. Other considerations. Gas trapping. Increased mean intrathoracic pressure may result from intermittent positive pressure ventilation in the presence of reduced expiratory time. If pulse pressure falls, neck veins appear distended, consider obstructed venous return and dependent fall in cardiac output. Disconnect endotracheal tube from the circuit and push on the chest to release gas trapping. Preload should be restored as intrathoracic pressure reduces and pulse pressure and tidal volume should improve. Typical ventilator settings in bronchospasm includes high FiO2, low respiratory rate, and prolonged expiration and prolonged IE ratio. Accept increasing PaCO2 as long as SpO2 is adequate, i.e. permissive hypercapnia. Followed by incident reporting, consideration of need for referral for optimization of asthma control, and full explanation to the patient and or family, including written explanation of what has occurred.